Okay, it is now my pleasure to introduce Pei-Shen Zhao, who's going to present to you his work on a medical device innovation for anesthesia.
Okay, thank you, Dick. How to use this? Okay. Good afternoon, everybody. What I'm going to talk about today is a PZ airway. How do you do the last slide?
You can either just click mouse,
here, okay.
or you can do this. Yeah, it's okay.
Okay. But let me tell you something about PZ first. I did medical school and about 5 years surgery in China. And at the end of 1990, I came to the United States. I did my PhD in University of South Carolina. And in 1995, I came to Boston. So in the last 17 years, I've been in Boston. I did my anesthesia residency at the St. Elizabeth's Medical Center. And after graduation, I was in private practice for 5 years. In 2008, I came to Tufts Medical Center, and I've been staff here for 4 years. A little bit more about myself. In the last 7 years, I've been going back to China, because I'm from China, and giving the lectures at their national anesthesia meeting. So I made a lot of friends in Chinese anesthesia community. And also one interesting, I found a lot of my friends and my classmates in medical school, they are holding like administrative positions there. They're either president of the hospital or the department chair. So I think it's very beneficial if it's beneficial to our future business. And in the meantime, I also made many connections to the industry in China. Actually, the prototype of PZ airway has been made by this company, which is associated with the Tianjin University in China when I was there a month ago. And I also have some other ideas, and those 3 companies have signed confidential agreement, so hopefully they can make a prototype soon. All right, back to the airway, PZ airway we're talking about. It's an airway for difficult intubation. When patient comes to surgery, general anesthesia, one problem with general anesthesia is difficult intubation, which incidence is 6 to 10% based on the literature. And this is a regular intubation. This we call the laryngoscope. This is endotracheal tube. And this is the opening of trachea, or we call, you can see the vocal cord here. So normal intubation, no problem. But when this part, or opening of the trachea, is more anterior here, with the regular laryngoscope, you can now see the vocal cord. So you can now intubate the patient. And the standard, gold standard for this problem is fiber optic intubation. When we do fiber optic intubation, this is a bronchoscopy, this is fiber optic scope. So this pink thing is we call you can call oral airway or intubator. So we numb the patient's throat, and we put the intubator in patient's mouth, and then we load this endotracheal tube over the fiber optic scope, and then we use this tip of scope is flexible. You can direct the direction. So we put the scope through the intubator and looking for the vocal cord or the opening of the trachea. Once we see the vocal cord, we put the tube, this fiber optic scope, in the trachea, and then we slide endotracheal tube in the trachea and take the scope out and take the intubator out. Those are the currently available intubator. This is a Berman, it's a William, and it's of a spin. So you can see this doesn't have a front. This like part of the front wall is lacking, and this is too short. So some studies showed all the intubators I just showed you have a functional deficiency, and so far nobody has made any improvement yet. And the problem with the current available intubator is a fixed tube. So for the obscene I just showed you, it's too short. So the problem with difficult intubation, this part is here, and this is the base of your tongue. So if the tube or the intubator is too short, the base of the tongue will block the view. Or if everything is fixed, you cannot really push the base of the tongue up. And the second problem, you can see this connector on the endotracheal tube, and this intubator to canal the intubator is too narrow. So what we really do, we take this connector out before we load the endotracheal tube over the fiber optic scope. And after we intubate the patient, we put this connector back. But because of a lot of manipulations, so you have to be really careful. Sometimes during the manipulation, you can dislodge the endotracheal tube. You just put it in. So those things made me think about the PZ airway. This is PZ airway. This is the front and the lateral view of the PZ airway. You can see it's a front wall is longer than the back wall, so which can work as a regular laryngoscope. So this part, by pushing up, you can push the base of the tongue up, make the exposure of the vocal cord easier. This tells you how the PZ works. So you can push the front wall, keep pushing up, supposedly the base of the tongue here, so you can push the base of the tongue up, get a better exposure of the vocal cord. Eventually, you can disassemble the airway by keep pushing the front wall. The reason you want to disassemble, as I said, because if you put the connector back and forth, and after intubation, because of a lot of manipulation, you can dislodge the endotracheal tube. But if you can disassemble the airway, not this connector, so once you put a tube in, you can just slide the back wall out. So you don't have to disconnect. You don't have to have too much manipulation. So this will avoid the second problem. And also, if you look at the curve, the PZ airway is close, but not exactly close to the glass scope. Glass scope is very popular on the market right now, and it's very useful for difficult intubation also. But the problems with glass scope is very expensive, and not every hospital has it. And sometimes you can see the vocal cord with a glass scope, just because the vocal cord is so anterior, you cannot really intubate the patient. So in this situation, you have to use fiber optic intubation, or the PZ airway will be used. So PZ airway cannot replace glass scope, but it cannot be replaced by glass scope either. So a lot of situations like here, you have to use a PZ airway and fiber optic intubation. Interesting, this paper actually published, this is abstract from 2010, and actually it's published last year. And the study showed for experienced user, the glass scope and the fiber optic intubation, the efficiency is the same. So glass scope does not save time compared to traditional fiber optic intubation. Cost analysis, the current intubator we're using, this is a William, the pink one I showed you, and this is the white one. So they sell $3 to $4. And the estimated cost to make a PZ airway $1 to $2 to make PZ airway, especially if you make outside the United States, the labor will cheaper. And so the profit probably minimum is $4 to $5 each. And the potential market, I divided to like 4 different market: training market, clinical market, and outside the United States and some other situations. The training market, there are like 5,400 anesthesia residents each year in the United States, and they're required, before they graduate, they're required to do like 20 fiber optic intubations, but they don't have to do in 1 year, so there's 3-year training. So if you time 20 divided by 3, so each year you have 36,000 for anesthesia resident. So I did a similar calculation for ER resident and the ENT resident. So, and then remember the difficult airway incidence I mentioned 6 to 10%. I take 8% as average, and there are 21 million general anesthesia in the United States each year. So you calculate 1.68 million difficult intubations. But I give 85% market to Glasgow. If I take 15% market, it will be 252,000 difficult intubation per year. So I add them up about 330,000 difficult intubation per year. And as the previous slide, if I showed you if we sell $10 each, and probably estimated sale is 3.3 million. If we're more aggressive, we sell $30, we can sell like 9.9 million, close to 10 millions. And the other market, we talk about outside the United States. It's a European market, we would estimate equal to US market. And this market is the market in the other area of the world, probably equal to the United States market too. And additional market, this I don't have a statistics, but in the unstable neck, which trauma patient most time have an unstable neck, and Down syndrome patient, their neck is not stable, means they have some, like the C-spine is not stable, so you don't want to really manipulate too much their necks when you intubate. And fiber optic intubation, you don't really manipulate because you manipulate the scope. So it's the safest way to do those trauma patient and the Down syndrome patient. So if you add all these four markets, the potential PZRA market probably $10.5 to $31.5 million. All right, timeline to market. And the PZRA patent has been filed by Tufts Medical Center last year. And as I said, the prototype has been made a month ago. And next step, so we're going to make a more real airway and do the test. And all those probably take about 2 years. So I'm looking for like a $15,000 to $200,000 to develop airway prior to the market. All right, I was told I only have 20 minutes, so I only have 20 slides, but I have one more important slide I didn't show, which is an operation slide. So I would like to take this opportunity to thank my mentor, Dr. Andy Levin, and Nancy Weatherby, and Dr. Cross, and also our MD, MBA students, Rana, Alex, and Michael. And finally, I would thank you all for listening. And I would like to find some collaborators with the same interest to develop a niche device and business, which will have a mutual benefit. And also, this is the first of several anesthesia device invention. So I think with my connections and your help, I would like to develop a high-end product line that will explore the growing demand for cost-effective solutions in the market in and outside the United States. So if I don't have a time, I would like to talk more at this reception.